So welcome to Scarborough Health Network Grand Rounds. I've got a very interesting case today, case of hypercalcemia. As you know, I practice endocrinology here at Centenary. I've been here 31 years. And this was a patient that we saw together with Dr. Michael Chang and a few other of my colleagues in November of 2021. Next slide. So this is a young lady, 26 years old, who came to emerge with severe epigastric pain for 2 days, also nausea and vomiting, and she was seen on November 12th, 2021. So she was diagnosed with acute pancreatitis based on elevated amylase 807, lipase 1339, elevated alk phos. She had an ultrasound of her abdomen which showed gallstones, and a CT of the abdomen showed acute pancreatitis. Next slide. The causes of pancreatitis, so gallstones, alcohol abuse, high triglycerides, drugs as seen there, pancreatic cancer, abdominal surgery, abdominal injury, and hypercalcemia, which is what we're going to focus on today. Next slide. So these are her initial labs. As you can see, the patient has severe hypercalcemia. Calcium is 4.27 millimoles per liter. The patient has hypophosphatemia, phosphate's 0.43, and the parathyroid hormone level is significantly elevated at 218. So this is obviously evidence of primary hyperparathyroidism. Next slide. This is just a slide showing the various causes of hypercalcemia, causes mediated through parathyroid hormone excess, like primary hyperparathyroidism and tertiary hyperparathyroidism in patients with renal failure. And then there's, of course, non-parathyroid related or hypercalcemia of malignancy through various factors such as PTH-related peptide, vitamin D intoxication, granulomatous diseases like sarcoid and TB. And of course, medication can sometimes be associated with hypercalcemia, lithium, teriparatide, which is of course Forteo, excess vitamin A. And then there's other less common causes like hyperthyroidism, pheochromocytoma, adrenal insufficiency. Next slide. So parathyroid causes increased bone resorption. So when you have high levels, you get more bone resorption. You're losing phosphate from the kidneys, hence the hypophosphatemia that you see with hyperparathyroidism. There's increased calcium reabsorption in the kidneys, and there's actually increased calcitriol formation. Now, if you actually measure 25-hydroxyvitamin D in most patients with primary hyperparathyroidism, it'll be low. Okay, so all these contribute to significant elevations in calcium. Most cases of hyperparathyroidism are outpatient and they're mild. Next slide. And of course, this just shows the different mechanisms of the hypercalcemia in patients with malignancy. So most of the hypercalcemias we see in hospital are usually malignancy related. Some can be from hyperparathyroidism, and there you can see are the various mediators with hematological malignancies, lymphomas. You have higher levels of 125-dihydroxyvitamin D produced. With other malignancies like myeloma, you have tumor necrosis factor and interleukin-6 involved. With lung cancers, you have excess production of PTH-related peptide. So those are the various mechanisms that you see elevated calcium levels in malignancy. Next slide. So the two most common causes of malignancy, onward. Yes. Again. Again. And primary hyperparathyroidism and cancer. Okay. So in terms of hypercalcemia, we see this in about 1% of the general population, 3% are women. Most cases of hypercalcemia are due to hyperparathyroidism, so that's about 70% of outpatient hypercalcemia, and about 20% of inpatient hospitalized patients have hypercalcemia from hyperparathyroidism. In terms of cancer, most patients in hospital with hypercalcemia have cancer, at least 50%, probably more. And about 10% of all cancer patients will have hypercalcemia. So between the two diagnoses, primary hyperparathyroidism and cancer, that represents about 90% of patients with hypercalcemia. Next slide, please. There's another condition called familial hypocalciuric hypercalcemia that sometimes is a little difficult to differentiate in patients with mild hypercalcemia, whether they have hyperparathyroidism or this. Doing a 24-hour urine calcium will usually shed light, as the higher urinary calcium will be seen with hyperparathyroidism. And there is a formula there, as you can see, to calculate to see if your diagnosis is hyperparathyroidism or familial hypocalciuric hypercalcemia. Next slide. Getting back to our case. So on further questioning, she gives a history of 3 weeks of severe constipation, 4 weeks of nausea, and about a 30-pound weight loss. Next slide. On physical examination, there was a right neck mass palpable. There was no lymphadenopathy. Cardiovascular exam was normal. Chest exam was normal. She was recovering by the time I saw her from her pancreatitis, so she's feeling a lot better, but she still had some mild epigastric tenderness. There were no masses on abdominal exam, and the rest of the physical exam didn't really contribute to anything. So the main finding on physical exam was a right neck mass. Next. Okay, so before we try to figure out what's causing this, we have a patient that has a calcium of over 4. So this is something that we need. It's an emergency we need to deal with acutely, and treatment started in the emergency department. So what are the first line therapies for acute hypercalcemia? Next. Fluids. These patients tend to be dehydrated because they usually have polyuria and polydipsia. Next. Intravenous bisphosphonates. Next. And calcitonin. Although calcitonin has a tachyphylaxis and it loses its effectiveness usually 3 to 4 days into the treatment. Next. Denosumab can be used in patients if their eGFR is under 30 and they're in renal failure, as you would like to avoid bisphosphonates in those patients. Next. So give most patients with this will be probably not in renal failure, but will be dry, dehydrated. They'll need saline. They'll need to be well hydrated. And once their volume status is restored, you can give some IV furosemide, and that will also help lower the calcium level. But never give furosemide to a patient who's still volume depleted. And of course, in severe cases where patients have gone into acute renal failure, dialysis will be necessary. Or in severe refractory hypercalcemia not responding to treatment, patients have been dialyzed for that. And of course, if there's congestive heart failure. Next slide. So calcitonin works quickly. It inhibits bone resorption, and you give it at 4 units per kilogram every 12 hours. And as I said, it works for about 2 to 3 days. But after that, there's a tachyphylaxis. It may be decreased if you give it with glucocorticoids, especially in the setting of granulomatous disease or myeloma, where IV corticosteroids are necessary. Next slide. Bisphosphonates, IV pamidronate and IV zoledronate are used. In our patient, of course, pamidronate is given. Next slide. And again, you can use denosumab Prolia especially in patients with chronic kidney disease. If the eGFR is under 30, that might be a better treatment. 120 milligrams sub-Q does normalize the calcium in the majority of patients, and it can be given weekly. Watch for hypocalcemia and vitamin deficient patients. Next slide. And of course, patients who have either myeloma or granulomatous disease, corticosteroids are a treatment to lower the calcium. Prednisone, patients acutely sick might have to use IV Medrol. Next slide. So our young lady had an ultrasound of the neck, which showed a 3.7 by 1.8 by 1.4 centimeter neck mass, ovoid hypoechoic, well-defined in the right lobe. And it was demonstrating internal vascularity. Next slide. We went on to a NMCT SPECT scan, CT, and it showed a mass posterior to the right thyroid gland. There was no suspicious calcification or necrotic, and it measured 1.4 by 2.1 by 3.1 centimeters. Next slide. There's the lesion there, you can see outlined. Now, when you see the isotope, because remember, this was a SPECT scan, so technetium was given. Next slide. Should be able to see the mass lighting up there on the right side of the neck. So that's our 3.1 centimeter neck mass, which of course we'll discuss what that can be. Next slide. Another view of it. Onward. Next slide. So the discussion preoperatively was, is this a parathyroid adenoma or is it a carcinoma? It used to be thought that the degree of elevation of calcium or PTH might favor a carcinoma as a diagnosis, but in a recent study, calcium or PTH level cannot differentiate parathyroid adenoma from carcinoma. And usually it can be differentiated on ultrasound and palpability. So if you palpate a lesion, there's a high probability that it's malignant if you palpate sorry, there's background noise. Can people mute themselves? Thank you.
I remember that. I said that it's all from nephrology. We talked about cleanup, right? Well, the year before, like the first cycle is a little bit easier because I think you can carry over some stuff from training.
Can you mute yourself, please? Sorry. So I can continue the presentation. Okay. So on ultrasound, the features of malignant are that they tend to be larger, they're heterogeneous, echotexture, irregular shape, non-circumscribed margin, and they have intranodular calcification. And you may see local invasion. Again, that's more something you would see on a CT SPECT, not on ultrasound. Next slide.
Here you need 50, and then total you need to meet all the.
I think Andy Zhang, I think you're the one we can hear. Can you mute yourself? Hello, Andy? Okay. So our patient received IV hydration with normal saline. She received calcitonin, and she was given IV pamidronate, 90 milligrams. And by November 18th, recall she was admitted November 12th, her calcium was down to 2.88. And now we have, what is the definitive treatment? Of course, our next slide will show what we will use in our treatment. Next slide.
Another smart way of doing assessments. I think when they,
So this photo is from Patagonia. This is a Patagonian explorer by the name of Dr. Michael Chang, who happens to do surgery at Centenary as well, and he operates on neck masses. He also does a lot of OR photography. So let's see what he removed. So she had a parathyroidectomy on November 19th. Next slide. So this is the lesion. So who thinks that's an adenoma and who thinks that's a carcinoma? You can unmute and say, you can guess.
Adenoma.
Adenoma? Oh. Who says carcinoma? Anyone say carcinoma? Okay, next slide. It is a parathyroid adenoma. I mean, it's the largest one I've ever seen. I'm sure Dr. Chang hasn't seen any large one. Michael's now on the OR table. He might be able to hear us, but he can't communicate to us. But I think, Michael, that was your largest adenoma. Onward. So postoperatively, our patient did well. By November 20th, her ionized calcium was 1.33. The normal range is 1.135. Her PTH was back to normal. She was feeling a lot better, and she was discharged home. Now, what can happen after parathyroidectomy? What should we be looking for? The calcium is normal there. Should we be monitoring calcium?
Absolutely.
Absolutely. What can happen?
Seizures, tetany.
So in other words, low calcium, right? Next slide. So yeah, by November 24th, she's now discharged. So this is an outpatient lab. Her calcium's down to 1.74. So she started on calcium and calcitriol, 0.5 mics BID. And by a month later, her calcium was even lower. She was having symptoms. She was having numbness in her extremities around her lips. Her calcium was down to 1.52. So we had to go quite high with her calcitriol and calcium. Eventually, her calcium level did settle. And next slide. So this is called hungry bone syndrome. And it's rapid and prolonged hypocalcemia, which this lady had it for more than a month, associated with hypophosphatemia and hypomagnesemia, and is exacerbated by suppressed PTH levels, which follows parathyroidectomy in patients with severe hyperparathyroidism, which is what our patient had. And it's due to an increased influx of calcium into bone due to the sudden removal of the effect of high circulating levels of PTH on osteoclastic resorption. And it tends to be worse if there's been long-standing hyperparathyroidism and there's evidence of hyperparathyroid bone disease. Next slide. So the photo on the left shows that that's a brown tumor associated with long-standing hyperparathyroidism. Photo on the right is just showing a osteolytic bone lesion for metastatic breast cancer. So onward. So this patient was seen in my office. I saw her in early January. She was hypertensive. She's quite obese. She was about 250 pounds. Her blood pressure was 142 over 104. So there is a chance that this could be part of an MEN syndrome or a multiple endocrine neoplasia. So she had investigations that were all normal. So there was no evidence of any pheochromocytoma or any other abnormalities in hormone. She did have an MRI of her abdomen as part of the workup for the pancreatitis. It turned out she didn't really have stones, but sludge, and her adrenals were normal. So there was no evidence at this point of any MEN syndrome, MEN1 being the pituitary, parathyroid, and pancreas, MEN2 being medullary carcinoma, parathyroid, and adrenals. She was referred for outpatient genetic testing. She had a virtual appointment with a geneticist. Unfortunately, she did not do the blood work, so I'm not sure if there was any charges with that, and she didn't do it, and she couldn't afford it. We tried to contact her to see why she never did the genetic testing, but she does have a follow-up appointment in a few months with me. We tried to contact her last week, but there was no reply, so I don't know if she's traveling or what, but her last calcium level was 2.40. That was back in December, a couple of months ago. So she's doing well. We do need to do the genetic testing to see if she is at risk of, or if she has MEN, as she hasn't declared the other hormone abnormalities. So obviously this is a case of severe hyperparathyroidism. Most of our patients with hyperparathyroidism are mild and initially diagnosed as outpatient. And this is a young lady that presents with acute pancreatitis, which is interesting. So, but hypercalcemia and together with hyperparathyroidism should be thought of when seeing a young patient with acute pancreatitis who has no history of alcohol abuse or any evidence of gallbladder disease. And this is what was confusing in this patient, is that the initial ultrasound did show gallstones. So we were still querying why she had pancreatitis, but at this point it appears the hypercalcemia and the hyperparathyroidism are, and the pancreatitis is seen more in patients with hypercalcemia from hyperparathyroidism than it is from hypercalcemia of other causes. So next slide. I think that ends the discussion of the case. Any questions about the case? Okay, this slide obviously shows the island of Santorini, where I'll be heading soon. So thank you, everyone. Thank you for taking part. Bye for now.